Yeah.
So we are live now. Good evening, friends. And we are actually waiting for people to join our program. So this is a very important day for me. The reason is because we are doing a grand rounds from my alumni, that is from Madras Medical College, which is actually a very, to me, my mother home, my mother pitch, the college which made me what I am today. And we're going to have a grand rounds from Madras Medical College, which is actually uh, a very proud moment for me. And we are waiting for people to join. So, hi, you can all type when you join, please type on my YouTube channel so that I can read your questions. Hi, Dr. Satya, Dr. Prithvi, Raj. So, I'm sure that we'll be joined by at least 10,000 people plus. I'm very sure that Dr. Amulya, welcome. Dr. Ankur, Danani. This is going to be a very, very nice program of grand rounds. And actually, you know that Alembic has always strived for excellence in the field of academics. And we have brought to you several good programs. Hi, Dr. Kavita from Kuwait. So we have people joining in from all parts of the world, looking at us actually. Alembic has always been propagating academics throughout the whole tenure of its association with Royal Pearl Hospital. And I have always been like a brainchild, giving them a lot of ideas how to propagate academics to each postgraduate and each doorstep, so that learning can become free of cost, as well as it can be seen throughout the world. This is a platform where the whole world is actually seeing us, and now we're being joined by a lot of people. Welcome, Dr. Nitin Mittal. So today is the grand rounds. So we have a very important concept of Meet the Legends, where we have brought almost top people in the field of ENT. And now we have grand rounds, and that grand rounds is something like a mock MS exam, and these are being executed by Alembic. And today we have none other than one of the best and closest friends of mine, Professor Anthony Irderajan. And I'm going to briefly read his CV. And if I start reading his CV, then this itself will be a complete program. So what I'm going to do is to cut short a little bit and then just give the salient features about Professor Anthony. So Professor Anthony Francis Irderajan is actually from Chennai, and he did his MBBS, he did his MS and his DLO in Madras Medical College, and we are classmates since MBBS. That is from maybe around 25, 26 years now. We are classmates. We know each other, and I always call him the encyclopedia of ENT. And if I have a doubt in ENT, I just phone up to him, and over phone I get a consultation. So he was formerly a senior assistant surgeon and professor of. He is now the professor of and head of department in Madras Medical College, and so he was also working in Salem as the professor and HOD of that government hospital in Salem, and he has been also the HOD and professor in Stanley Medical College, and now he is the professor of ENT Madras Medical College. And what is his specialization? His specialization, you would have seen a number of videos of him of endoscopic ear surgery. He is a real master in endoscopic stapedectomy. I have personally seen him operate. We have done a masterclass with him here in TRICHY. He is really brilliant in surgeries as well as in theory. He's done over 3,000 middle-ear endoscopic ear surgeries, including stapedectomies, tympanoplasties, cholesteatomas, and he is actually done several kinds of work, like, he does endoscopic sinus surgery, he's a skull-based surgeon, and his interests are in endoscopic ear surgery, and he takes keen interest on teaching. So, in fact, he's done numerous regional, national, international workshops. He's given lectures, keynote presentations, orations. He's been a panelist in several international workshops. These are just a few accolades which I'm talking about him. Actually, when you experience this grand rounds, you will know the depth, the in-depth knowledge of this personality, whom I'm, you think that I'm praising so much. I know by heart that he's one of the best, knowledgeable ENT surgeons in the world. And today we have with us Dr. Raghavi, and Dr. Raghavi is one of the very, very bright ENT surgeons of India in the making, and she is a third-year MS postgraduate, and you will be having a case of hypopharyngeal growth, and they are going to discuss, and this is going to be like, I've asked Professor Anthony to give A to Z of hypopharyngeal growth. So it might run 2 hours together. You'll have to stay with us, and really you can put forth your questions. Dr. Vaibhav Patel, Dr. Ankur, Dr. Sri Harsha, you're eagerly waiting, I know, and the exams are going to come on the way now, and this is just going to be one of the treats for you. And we did a few grand rounds with Ahmedabad, with Professor Vishwakarma, and we did 2, and then we are going to do 1 again on 22nd with Professor Vishwakarma. In between, we'll have also Madras Medical College and some other medical colleges also. So over to you, Professor Anthony. Thank you very much for your time, and it's going to be a brilliant treat for the whole world of postgraduates. And over to you now, please.
LNG group is welcome, Dr. Anthony, sir.
Good evening, everyone. Today we are going to see a case of hypopharyngeal growth, which has been presented by our senior MSPG. I am Dr. Anthony Rajan Francis. I head a unit in Madras Medical College. And why we have selected hypopharyngeal tumor is because the long case for the MS postgraduates will be usually a throat case, even for a DLOs. The throat case usually we get is the laryngeal growth, but due to the paucity of these cases these days, we are keeping cases for hypopharyngeal tumor also. So that's also one of the important long cases in MSc curriculum. So we like to discuss that by I'm introducing my postgraduate, Dr. Raghavi. You would have just seen her. She is a double quiz winner in our AOICon this year, and she will present the case.
Dr. Raghavi,
Yes, sir.
Dr. Raghavi, this is being seen throughout the world. I can see the tension in your face. Just relax and just keep cool. I know you're one of the most brilliant postgraduates. Just keep cool and go with the flow. All the best.
Thank you, sir. Good evening. I'm Dr. Raghavi. I'm going to be presenting case of 60-year-old female, Mrs. Suganti, a housewife from Maniambadi, came with chief presenting complaints of difficulty in swallowing for the past 2 months and voice change for the past 1 month. History of presenting illness. The patient was apparently normal 2 months ago when she developed dysphagia for 2 months, which was insidious in onset, progressive in nature, more for solids, no aggravating or relieving factors.
Yeah. See, the thing is, I'm going to interrupt you here and there again and again, so don't lose your track. Because not only to examine you, but to propagate the knowledge of asking these questions. Okay. So, what is dysphagia?
It's the abnormality in transition of food and
Don't get tensed up. It's only a think this is a board presentation, right? Fine. Tell me.
abnormality in transition of food and endogenous secretions from the oral cavity to the stomach.
Yeah, there's a defect in the transportation of the food, micronutrients, and endogenous secretions like saliva to your from the oral cavity to the stomach is called dysphagia, right? It may be complete obstruction or it may be incomplete obstruction. How do you classify dysphagia?
Grades.
Grades of dysphagia.
Grade 1 is for solids.
Grade 1 is for solids.
Grade 2 is for semi-solid.
Grade 2 is for semi-solids.
Grade 3 is for liquids.
Grade 3 is for liquids.
And grade 4 is absolute dysphagia even for saliva.
Even for saliva. Yes, very good. But actually the dysphagia is classified according to the local needs, right? The food, when you say solids, liquids, things like that is very vague terminology. In Madras Medical College is one of the foremost institutes where there is a medical gastroenterology department headed by a great professor called Dr. Madana Gopal. We have a classification called Madana Gopal's classification for dysphagia. This Madana Gopal classification tells you that, for example, the grade 1 dysphagia is for solids. We call that the dysphagia for food like chapati and parota, where you got to mix it well, and then you got to swallow it. You can't swallow a chapati or a parota, then we call it as a grade 1 dysphagia. Grade 2 is for semi-solids, but it's taken for rice, soft boiled rice. Grade 3 is for semi-solids, like you can't take it for something like kanji or semi-solid diet. Grade 4 is for the liquid, and grade 5 is for the even the saliva, we call it an absolute dysphagia. Not only this, when you swallow something, a food stuck to your food pipe is also called dysphagia. The causes for, what are all the causes of dysphagia?
Depending on the site of site causing the dysphagia can be classified as oral, pharyngeal or esophageal.
Yes, when you ask a question, right, the idea of making an examination for a student is that student should keep on talking. So when the question is asked, you rattle out with a cause. They ask a cause for dysphagia, rattle out with the causes, say oral causes, pharyngeal causes, esophageal causes. For example, esophageal causes means inside the lumen, on the wall, or from the outside. So when you keep on talking like this, you have a lot of causes to tell. The number of questions fired at you will be lesser. If you keep on thinking, telling one or two answers and wait, the number of questions or avenues to ask questions will be more. You tell something rare, they will ask in that. It's like we are digging our own grave, right? So we generally classify this to oral causes, pharyngeal causes, and esophageal causes. That all standard books will tell you what are all the causes. Okay. So once we have finished this history taking, we are going to tell you, is there a lesion? If there is a lesion, where is the lesion? What is the lesion? Okay. So present.
History of voice change for the past 1 month. It's insidious in onset, progressive in nature, hoarse in character. It's non-remitting. It's not associated with voice fatigue, and there's no aggravating or relieving factors.
Okay. What is voice change is called?
Hoarse.
Change of voice is usually called dysphonia. Okay. So the change of voice can occur because of the oral causes, oropharyngeal causes, or it can become a laryngeal causes. Okay. So a tumor which is in and around the laryngeal inlet or above is usually causes what is the type of voice?
Potato voice.
It's called hot potato voice. It may be because of the posterior one side of the tongue growth, or maybe a supraglottic growth, or maybe a growth which is on the superficial part of the piriform sinus. That will be in a hot potato voice. Hypopharyngeal tumor can cause laryngeal involvement. Then the change of voice will be different. So when you say hoarseness, that means the voice is affected the larynx, particularly the vocal cord. What is hoarseness?
Hoarseness is the harsh Harsh voice not the characteristic of age, sex, or race.
Yeah, a voice which is not peculiar for a particular age, character, or sex. It's a harsh, discordant voice which is not characteristic of the patient's age, sex, or character is called hoarseness. For example, a child talks like an adult is an hoarseness. An adult talks like an adult is not an hoarseness. Similarly, a lady talks like a male is an hoarseness. It's usually harsh in character. So when you talk of an hoarseness, it means you are talking about some vocal cord abnormality. Usually it is not closing properly because of a mass lesion on the vocal cord or maybe mobility disorder. Okay, right, present. So you are talking about a change of voice which is progressive and which is unremitting and no associated fatigue and is hoarse in character. Okay, yes, present.
She had a history of foreign body sensation in the throat for 6 months.
Any side?
On the left side.
On the left side, yes.
She also had a history of odynophagia for the past 1 month.
Okay.
History of left ear pain for the past 1 month.
Every time you see a odynophagia, we think of infection. But in the case of a pyriform fossa tumor, when there's a nerve involvement is there, you still have an odynophagia. Okay. Like so, why there is a left ear pain?
Referred pain will be there.
Usually, it may be any other pathology also. It is too early to say the referred pain is because of the pain in the ear is because of a referred pain, but it can be because of referred pain also. Okay. So, what is the nerve which causes referred pain?
In the pyriform fossa, there is internal laryngeal nerve, which is the branch of the superior laryngeal. It's the branch of the vagus nerve. Vagus nerve also supplies the deep part of the external aortic canal through the Arnold's nerve.
What is another name of an Arnold's nerve?
Alderman's.
Alderman's nerve. Why it is called Alderman's nerve? Yes, alderman are a group of clergies, right? They are a group of clergies. So they used to go to various places, eat well, and bless these people. So to bless, you got to take a lot of food. But if you can't keep on taking food more than 3 to 4 times a day, so what they used to do, they used to pour alcohol in their ear. So once they pour alcohol in the ear, that will stimulate their vagus and increases the gastric motility. So these people are called, that's why it's called an alderman's nerve. Okay. So the people in those days itself knows that if you stimulate your ear, your vagus will get stimulated. Like when you remove the wax, patient stops coughing. Like that, it will increase the gastric motility. Okay. The next.
History of loss of appetite and loss of weight was also present. Patient did not.
What does that signifies? Loss of weight.
Loss of weight signifies can be because of dysphagia or because of malignant gastritis.
So the disease is progressing and the patient is not remitting from the disease. So progressive dysphagia will cause loss of weight. Okay, right.
No history of difficulty in breathing, no history of aspiration, no history of cough with expectoration, no history of fever, no history of hemoptysis or hematemesis, no history of any swelling in the neck.
Okay. Next.
No history suggestive of reflux diseases. No history of neck stiffness.
Why neck stiffness?
Sir, any prevertebral extension of the tumor to the prevertebral region.
Will produce? You can't classically say stiffness in the neck. The patients will feel difficult to lift up his chin and look up. This will happen whenever there is a the tumor which is infiltrating on the prevertebral fascia. And then the posterior pharyngeal wall tumors usually goes to the retropharyngeal space. A tumor secondary nodes in the retropharyngeal space can cause an infiltration of the muscles, and lateral node of fluvius involvement can produce a symptom like neck stiffness in the patient looking up. Okay, right.
No history of bone pain, no specific ear or nose complaints was there.
But you said the patient has got a ear pain,
except for left ear.
except for ear pain. Okay, right. No history of nasal. Okay.
Past history, she's not a known case of diabetes mellitus, hypertension, coronary artery disease, bronchial asthma or TB.
We are all forgotten one disease which we used to talk a lot the previous things. It usually affects a lot of places in ENT, that is syphilis. So they should add diabetes, hypertension, tuberculosis, sexually transmitted disease, or exposed to tuberculosis or sexually transmitted disease. These are all the 5 things we should do. You should come to. Then what else?
She had a history of hemithyroidectomy done 20 years ago. Elsewhere, details are not known. No
Do you
history,
think this is significant?
can be a thyroid malignancy, which is
Very rare. Thyroid malignancy will involve larynx. It doesn't involve hypopharynx.
if we have already done a neck surgery, then while doing surgery, there might be fibrosis or adhesion.
Yes. Okay. So that you should be kept in your mind. Right. Then
No history of previous blood transfusion, no history of previous radiation exposure, no history of any drug allergy.
okay.
Personal history, she comes from a low socioeconomic status.
What is the significance of low socioeconomic status?
Overcrowding, poor diet,
So poor diet can cause
malnutrition.
nutritional deficiencies, malnutrition can lead on to anemia. What is the relationship of anemia with the hypopharyngeal tumors?
Plummer-Wilson syndrome can occur, which causes
Usually a chronic anemia with the achlorhydria and siderophilic anemia.
Koilonychia, glossitis, cheilitis, then
So all
esophageal webs.
esophageal, all these things are all predisposing factor for a post-cricoid tumor. So, okay. So how does the Plummer-Wilson syndrome produces malignancy?
Sir, when there is that is an area of a lot of exposure to the foods. So when
Whenever there is a
decrease-
web, the contact area of the carcinogens to one particular point will be more. So there will be a chronic irritation. So this chronic irritation produces malignant transformation. You have known that in the case of achalasia cardia, there's almost a similar situation where there is a block and over that there is always some stasis. There is a fluid level. At the level of that fluid level, all the non-dissolvable carcinogens float. So this will irritate at that particular level. Particularly it happens in a post-cricoid web. So that will produce malignancy. Okay, right. Then
consumes mixed diet,
it's a diet.
normal bowel and bladder habits, no history of she's not a smoker or alcoholic, not exposed to passive smoking also. Menstrual history, she attained menopause 15 years ago. She had regular cycles with normal flow. Family history is not
Okay. Any family history of malignancy?
No, sir. No
Okay.
family history.
Right. So you have come to the end of your history, right? So what do you think the patient has got?
She has persistent symptoms.
Persistent symptoms, which
been
is
progressive.
progressive.
So there is a chance.
You are having a disease which is progressing.
Old age also. So
What is the duration? The female, the duration is short duration, less than 2 months, 3 months. So the chances for a patient who has got a progressive disease in the food passage. Okay. So yes, there is a lesion. Possible lesion is there in the hypopharynx. Okay. So it starts with the foot sticking sensation. It's not starts directly with the difficulty in swallowing. The 6 months patient had a foreign body sensation, foot sticking sensation in the throat. So it usually got to be a supraglottic posterior tongue or a piriform fossa growth. Okay, so these are all the possibilities, and there is a involvement of larynx. We don't think it's a laryngeal growth which will become a piriform fossa hypopharyngeal growth, because the first symptom is related to the foot pipe, then to the larynx. So most probably we are dealing with an hypopharyngeal tumor. Okay, the tumor which is in the food passage. Okay, right.
So on examination, general examination, the patient was moderately built and nourished.
What is moderately built, nourished?
Built is the skeletal framework, sir, the bony structure. The nourishment is any recent history of intake.
Yes, a patient who is poorly built means what?
Childhood from the child.
Poorly nourished means what?
Poorly nourished is recent insults, sir, recent malnourishment.
Generally speaking, a long-standing malnourishment from the time of childhood will cause poor built or moderately built. Sudden loss of weight will cause poor nourishment. Okay, or okay, then.
She's conscious oriented, comfortable at rest, not in stridor. She's afebrile. No pallor is present. Her nails are normal. No cyanosis, clubbing, pedal edema or ictus. No generalized lymphadenopathy. She has a horizontal screen crease scar in her lower part of the neck.
Okay.
Oral cavity, lips, gums, gingivo-buccal sulcus, gingivo-labial sulcus, buccal mucosa, retromolar trigone, hard palate, anterior two-thirds of the tongue and floor of mouth are normal. There's no features of glossitis or anglostomatitis. In oropharynx,
any staining?
no, sir. No nicotine staining was also.
Is there any pre-malignant lesions?
No, sir. No.
What are the pre-malignant lesions of the oral cavity?
Leukoplakia, erythroplakia, erythroleukoplakia,
erythroleukoplakia, lichen planus. Okay. Sharp teeth.
Sharp teeth, spices. S6, S5, S6.
That is history. Okay. Papillomas, benign tumors. Okay. Then
oropharynx, uvula, soft palate, anterior pillar, tonsillar fossa, posterior pillar, posterior one-third of tongue and posterior pharyngeal wall are normal.
what is the difference between the oropharynx and the oral cavity? What is the demarcating point between the oropharynx and the oral cavity?
Sir, superiorly the junction between the hard palate and the soft palate, inferiorly the circumvallate papilla, laterally the anterior pillars.
Anterior pillars. Okay. So that's called
The
oropharyngeal isthmus. So oropharyngeal isthmus is the one at the level of a circumvallate papillae and the hard palate and soft palate junction. That makes soft palate is the part of oropharynx. Okay. What is the demarcation point between the oropharynx and the hypopharynx?
Sir, the vallicula, the epiglottis, the lingual and laryngeal surface, pharyngoepiglottic folds.
Lateral pharyngoepiglottic folds is a demarcating point between the vallicula and the pyriform sinus. So that is the demarcation between the oropharynx and the hypopharynx. Okay. So you mean to say, how do you demarcate between the posterior pharyngeal wall of the oropharynx and the hypopharynx?
Sir, the superior border of hyoid bone is the demarcating line.
How do you know hyoid bone?
Sir?
How do you know hyoid bone?
Or the floor of the vallicula is taken as the
Yes, pharyngoepiglottic fold.
pharyngoepiglottic.
So from the imaginary line at the level of a soft palate to the level of a pharyngoepiglottic fold, what the posterior pharyngeal wall you see is the posterior pharyngeal wall of an oropharynx. When you see a tumor, how do you say which tumor is the posterior pharyngeal wall tumor and which tumor is the post-cricoid tumor?
Best test using a tongue.
Yes.
Using a tongue depressor, we depress and we can look at the tumor, then it's a posterior pharyngeal wall tumor. We cannot look at the tumor, then it's a post-cricoid tumor.
Yeah, this is what we have been taught all along. You take a tongue depressor, put your tongue depressor and see, you see a tumor that is a posterior pharyngeal wall tumor. If you don't see a tumor, you can see the tumor only on indirect laryngoscopic examination. It's called a post-cricoid tumor. That is gone. Because now you know the posterior pharyngeal wall is the whole thing from the level of the base of the skull to the
Cricoid inferior border.
Inferior border of the cricoid cartilage or cricopharynx. So the whole thing is a posterior pharyngeal wall. So now there is no question of putting a tongue depressor to say whether it's a postcricoid or a posterior pharyngeal wall. Whether you see a tumor on the posterior pharyngeal wall on postcricoid area or on the hypopharyngeal area or oropharyngeal area, all the tumors are all called a postcricoid tumor only. It is not a all the things are called posterior pharyngeal wall tumor only and not a postcricoid tumor. Okay, right.
On indirect laryngoscopy.
Sorry to interrupt. Hello, Professor Anthony?
Yeah, listening to you.
So we'll make it like a discussion also.
Yes.
So there is a question, UICC classification of anatomical subsites of the hypopharynx.
We'll come to that later, or you want to discuss it now itself?
No. I mean, I just putting forward the questions which are coming.
Yeah, okay. What are the subsites?
Pyriform fossa, postcricoid region, and posterior pharyngeal wall.
There are three subsites for a hypopharyngeal tumor. They are called lateral foot channel, otherwise called a pyriform sinus, a posterior pharyngeal wall, and the postcricoid area. Okay.
Thank you.
Yes. So, what are all the things when you notice when you do a indirect laryngoscopy examination?
So the base of the tongue, the vallicula, the median and lateral.
We call this the posterior one third of the tongue.
Posterior one third of the tongue.
Okay, posterior one third of the tongue.
Vallicula, median and lateral glossoepiglottic fold.
Okay.
The epiglottis.
You talk about median and lateral glossoepiglottic fold. Next, what you should talk of? Lateral pharyngoepiglottic fold. Isn't it? Yes.
Then the
epiglottis.
Then in the pyriform fossa.
See, there is a way of presenting a indirect laryngoscopy examination. You can present straight away what you see, the growth, and then you talk about everything else, or you go from above, go to the growth, go to the larynx or hypopharynx, and then you present. If it's a posterior one third of tongue growth, you present it, it's a growth in the posterior one third of tongue, blah blah blah, tell all the extents, and then you go and say both pyriform fossa, the larynx, area epiglottic fold, false vocal cord, true vocal cord, everything appears normal. Okay. Or if there is a growth in the pyriform sinus, you can tell posterior one third tongue, vallicula, epiglottis, area epiglottic fold appears normal on the left side. Then you got to present. Okay. Yes, present.
So there's an exophytic whitish slough-covered proliferative growth present in the left pyriform fossa, extending to the left aryepiglottic fold and the left arytenoid. There is fixation of the left hemilarynx and pooling of saliva is present in the left side. Right aryepiglottic folds is normal. Right arytenoid is normal and mobile. The right ventricular band and the two vocal cords are normal and mobile.
Sorry, I saw this video and I saw this presentation, but I didn't correct you. Okay, this is the exact description for a vocal cord growth. Left hemilarynx is fixed, means the only left side of an hemilarynx is not moving, but you could see the false vocal cord and true vocal cord, isn't it?
Yes, sir.
Did you tell that?
Vocal cord and the ventricular band is normal, but they are not mobile.
They are not mobile. Yeah. So it is a fixed cord, but it is not mobile. Okay. Then what else you should tell? The patient is not in stridor. It means what?
Glottic chink is adequate.
Glottic chink is adequate. When you say that glottic chink is adequate, what do you see through a glottic chink?
Subglottis is normal.
So I got a strict instruction from our projection team that there is no match fixing. So I didn't tell about that to you. Sorry. Okay. So what happened?
Yeah, we can see. We can see the video, but the video is not playing.
That's what. How come suddenly it's not playing? Yeah. Okay, this is the tumor.
Okay.
Um, okay, this is agreed. Slough covered proliferative tumor. What are all the types of growth which occurs in the post hypopharynx?
So it can be exophytic or
Exophytic.
infiltrative.
Exophytic, which is otherwise called ulcerative,
Or
or
infiltrative, submucosal.
infiltrative is the character. You can be polypoidal, sessile or polypoidal. Where will you get sessile tumor or a polypoidal tumor? So that means you are talking about a tumor which is polypoidal, means that mucosa should be intact, right? Mucosa should be intact. Where will you get a intact mucosa tumor?
Dr. Raghavi, keep the mic close to you, madam. Yeah, we are not able to. Okay. Yeah, please carry on.
Postcricoid region.
No, you see a tumor which is subepithelial. What do you see on subepithelium? Below the epithelium is made up of what type of tissue? This is epithelial tissue. What is the tissue which is in the below the epithelium? What? That's a mesenchymal tissue. So an epithelial tumor is called, malignant epithelial tumors are called carcinomas and various type of carcinomas. It may be a squamous cell carcinoma, adenocarcinoma, or something like that. Mesenchymal tumors are called what? Sarcomas. So it's very rare in hypopharynx, but if you see a sarcoma, usually this sarcoma is arising from the underlying soft tissue. So underlying soft tissue tumors will usually be within intact mucosa unless it is very big. Okay. So which tumor, soft tissue tumor will, so these are all the three types of tumors. It can be a polypoidal, or very rarely it can be polypoidal. Usually it is a exophytic tumor. It's a cauliflower like. So when you describe the tumor, margin of the tumors are all everted. So same thing can happen with the ulcerative lesion, where the margin will get evected and the mucosa can contain slough. Okay. So the characteristic features of malignancy is when okay. So this is about the tumor. Okay. You can see one side the card is little lateral. So you can't say it is medium. Okay. And then okay, what are all the other ways of, this is the video laryngoscopy, right? How do you do video laryngoscopy?
With the patient in sitting position after
Sitting
spraying
position.
local anesthesia.
Spraying local. What is the local anesthetic you spray?
4% xylocaine.
If you have a controlled way of spraying, which one you prefer?
10%.
10%. Okay. Right. Then you got to explain the procedure to the patient. Then you make the patient sit comfortably. If possible, give a iPad, anesthetize the oral cavity, oropharynx, then put a angled endoscope. Right. What angled endoscope you prefer?
70 degree or 45.
45 degree or 70 degree. Usually people use 70 degree or 90 degree endoscope, but I prefer 45 degree endoscope. It's only our comfortability. Okay. So with that, you go inside.
Behind
See, the trick of learning this for the first year is that you sit down in front of the patient, hold the tongue, take your endoscope inside. When you take an endoscope inside, you will take the endoscope straight. once you have gone to the beyond the level of the tongue, then stand up. If you stand up, you can see the larynx straight because the angulation will become perfect. If you are standing up and try to insert it, you will find it little difficult. So sit down, go inside, then stand up. You can see the video laryngoscopy better. Okay. So one is the video laryngoscopic examination. You get a little bit of distorted picture with all these endoscopes and all your angulations. What is the better way of looking at it?
Direct laryngoscope.
OPD. We don't use this generally. That's why I asked this question. Actually, flexible nasopharyngoscope or flexible laryngoscope will give you a better picture than this. You get the good picture. You can see this picture little bit anteroposteriorly compressed. So there you get the exact picture. So what is the difference between the direct laryngoscopy and the indirect laryngoscopy?
In direct laryngoscopy, we get the real image. In this, we get an inverted image.
Yes, inverted image.
It's distorted. It's shortened anteroposteriorly.
Anteroposteriorly it is shortened.
And then hidden areas are better seen in direct laryngoscopy.
Okay.
And then for biopsy or
what is the color of the vocal cord?
Pale.
So here it will be just whitish in color. There it will be a little bit of pale and pinkish.
Palish, pinkish.
Okay, so the color will be much differentiated with the direct laryngoscope. Then we can do other procedures along with that.
This is only diagnostic.
This is only diagnostic. There you can it can be diagnostic as well as therapeutic. You can take a biopsy with the direct laryngoscopy. Anything else you do? What is probe test?
To check if there is cricoarytenoid fixation or it's a palsy of the vocal cord. So we can
Okay.
palpate
So you can palpate and see whether the cricoarytenoid joint is mobile. Okay, why this patient has got a fixed cord?
So it's a pyriform fossa growth.
No, what are all the causes?
Paraglottic space involvement can cause. Rectal-laryngeal nerve involvement can cause.
Where the rectal nerve will get involved?
Cricothyroid muscle when there is an apex of the pyriform fossa from there. It's
How it
closer to
comes
the
out?
cricothyroid muscle.
Cricothyroid muscle.
Cricothyroid muscle.
Cricothyroid membrane. How does the tumor comes out of the larynx? Apex of the pyriform fossa tumor. How it comes out of larynx?
Cricothyroid membrane.
Cricothyroid membrane. Is it? I think it was cricothyroid membrane is in the larynx. What is the relationship of cricothyroid membrane with the pyriform sinus? Keelius dehiscence. Okay. See the inferior constrictor muscle has got two parts. What is called a thyropharyngeus, what is called a cricopharyngeus. Thyropharyngeus forms the border of lateral wall of the pyriform sinus. While cricopharynx doesn't come to the apex of pyriform sinus. When you see the cricopharyngeal muscle, that means that's a upper esophagus. It's an upper esophagus. So in between you have a gap through which it comes out. It can enter the rectal laryngeal. The ways of pyriform sinus growth causing vocal cord fixity are, it can cause fixity or palsy. Fixity is one is the medial extension into the paraglottic space. So what is a paraglottic space?
Paraglottic space is bound medially by the It's medially bound by the quadrangular membrane and inframedially by the conus elasticus. Laterally by the thyroid cartilage. Posteriorly, it has the anterior reflection of the pyriform sinus mucosa.
See the boundaries of paraglottic space. Paraglottic space is nothing but the space where the saccule is there. Or you take a pin and puncture the anterior wall of the pyriform sinus and the medial wall of the pyriform sinus. Where you go, that is the paraglottic space. Anteriorly, it communicates with the preepiglottic space. Posteriorly, by the anterior reflection of the pyriform fossa mucosa. Superiorly, by the mucosa covering the ariepiglottic fold. Okay. Inferiorly, it comes up to the level of the cricoid cartilage. So, medially, above you have a quadrangular membrane, then you have a saccule, below you have the conus elasticus. So that's a paraglottic space. So in the saccule, the the medial fibers of the thyroid muscles are called vocalis muscle. So vocalis muscle are on the edge of the saccule. So a tumor which involves the paraglottic space, first it involves the entire length of the larynx. So you can't give a cancer clearance on one side alone. So you got it involves supraglottic as well as the vocal cord level and below the level of vocal cord, and then it adjacent to that is your vocalis muscle. So it causes fixation by causing the infiltration on the vocalis muscle. So it's a deep infiltration. Okay. Second thing is it can directly go and infiltrate on the cricoarytenoid joint. Very rarely it can come out of the hypopharynx, can get involved in through the apex of the piriform fossa, through the Killian dehiscence, and can cause a recurrent alveolar paralysis. Okay, these are all the three ways a tumor can cause vocal cord fixity. Okay, the patient, in this case, you have not seen the ideal examination. You think it's a piriform fossa growth. Okay, this patient also gives history of sound coming from the patient, and the patient is sleeping. What do you think?
Posterior, post-cricoid area, probably through the posterior cricoarytenoid muscle. Then there is bilateral palsy.
So bilateral vocal cord palsy can present as sound. It need not have stridor always. Sometimes it can produce when the vocal cord is not completely closed, it will not be adequate when the patient is sleeping, can produce noise when the patient is sleeping. Okay, it's the stridor can come when the patient is sleeping. People who are around us can think it is the post-cricoid. We had a case here where the patient was evaluated for snoring and sleep apnea, got admitted, patient went to sleep lab, underwent sleep PSG. AHI is 0, but patient had the noise while breathing. So they have sent the patient back saying that AHI is 0. But when the patient came to us, we just put an endoscope inside and saw there was a bilateral abductor palsy. So a patient can have a bilateral abductor palsy, can present as a sleep apnea, can be treated for sleep apnea. So every time you are going to get a patient who is complaining of noisy breathing while sleeping, it may not be only snoring. You got to do a thorough general ENT examination, which is mandatory. Okay, so a post-cricoid growth can produce a bilateral abductor palsy. Okay, so bilateral abductor palsy can cause, can be the only presenting symptom of a post-cricoid growth also. Okay, then examination.
Neck examination. On inspection, the external laryngeal contour was normal. There was no thyroid cartilage splaying. Trachea was in the midline.
No, this patient should have a thyroid cartilage splaying, isn't it?
Yes, but it should not.
No. Thyroid cartilage splaying will come in which type of piriform fossa growth?
Medial.
What part of piriform fossa is involved in this patient? You think this is superficial?
So she has left ear pain and nodinophobia.
When you have a tumor at the level of the pharyngoepiglottic fold, that is a superficial part of the piriform sinus. Okay, so this is very close to the apex of the piriform sinus. So when the tumor which is on the superficial part of the piriform sinus will produce unilateral splaying of the laryngeal cartilage. It comes only when the patient has got a tumor which is at the superficial part of the piriform sinus, not when the patient has got a deep part of piriform sinus. So to come to that, we'll go to our question. What are all the boundaries of piriform fossa?
Sir, it's a inverted pyramidal shaped structure. So superiorly the pharyngoepiglottic fold, inferiorly the cricopharyngeus, The piriform fossa as such is divided into two parts, the superficial and the deep part. The superficial part medially is by the aryepiglottic fold, laterally is by the thyrohyoid.
It is partly membranous,
partly cartilaginous.
partly cartilage. The membranous part is lined by the
aryepiglottic fold and thyrohyoid.
thyroid is lateral.
Lateral.
Laterally, lateral wall is partly membranous, partly cartilaginous. The membranous part is the thyroid membrane, and the cartilaginous part is
Thyroid cartilage.
thyroid cartilage. Okay, very good. Then
Medially, the aryepiglottic fold, and inferiorly,
the apex of the piriform fossa,
is cricoid cartilage.
laterally
Thyroid cartilage.
thyroid cartilage, medially cricoid cartilage. Okay, so where do you, when you dissect, what is the differentiating point between the cricoid piriform sinus and the post-cricoid area?
Abducted when the vocal cords are in the cadaveric position, a vertical
No,
line.
that is clinically. When you dissect, how do you know?
Between
You have two muscles.
the
You have two muscles. One is posterior cricoid knot, other one is
lateral
cricoid knot. The cricoid cartilage with the lateral cricoid knot is the piriform sinus. Your posterior lamina of the cricoid cartilage with the posterior cricoid knot muscle is the post-cricoid area. Okay, that's why in the case of a post-cricoid growth, you get an infiltration of the posterior cricoid knot muscle very commonly. Okay, so mucosal fold between the arytenoid and the posterior cricoid knot muscles forms the starting part of the post-cricoid area. Okay, so what is the anatomy of the post-cricoid area?
So there's a strip of mucosa from the inferior part of the arytenoid to inferior part of the cricoid.
Inferior part of the cricoid cartilage. Okay, cricoid cartilage. Fine. Otherwise, a cricopharyngeus muscle. Okay. So the post-cricoid area, when we are all studying, is an area where the apex of the piriform fossa ends. It's a siphon-like area which is from the level of the arytenoid to the level of the cricopharynx. But when you take a posterior pharyngeal wall, actually you can't differentiate between the level of ending of posterior pharyngeal wall and the start of a post-cricoid area. Similarly, you can't demarcate between the apex of the piriform fossa and the lateral wall of the post-cricoid area. So they have already removed that the piriform fossa is they already removed that piriform fossa goes up to the cricopharynx. Posterior pharyngeal wall goes up to the cricopharyngeus muscle. Only the anterior wall of the hypopharynx, which is behind the larynx, is the one which is the post-cricoid area. So it post-cricoid area involves a strip of mucosa from the level of the arytenoids to the level of the lower border of the cricoid, or otherwise at the level of the cricopharyngeus muscle. Okay, right. So where are all how does the what is the posterior pharyngeal wall? What are the boundaries of posterior pharyngeal wall?
Superiorly, the hyoid line drawn from the superior part of the hyoid bone. Inferiorly, inferior border of the cricoid line drawn from, that is a superior and inferior extreme.
This is a very arbitrary area. When the vocal cords are in a
cadaveric position,
you draw an imaginary line. That's a demarcation between the lateral wall of the piriform sinus and the posterior pharyngeal wall. Extend at the level of the pharyngoepiglottic fold to the level of the lower border of the cricoid cartilage. That strip is called the posterior pharyngeal wall, but not like a larynx. When you say a supraglottis, glottis or subglottis, in the case of a post-cricoid area or a hypopharyngeal tumor, there is no barriers. When you say a tumor from the vocal cord or a glottic tumor, it needs to cross a barrier to go to a subglottis or needs to cross a barrier to go to the supraglottis. But in the case of a piriform sinus tumor, or in a posterior postcoital tumor, there is no such barriers. So it can simply go. So the demarcation between these areas are all very limited. Okay. So, okay, we go to the presentation again. Okay, then no thyroid splaying.
Trachea is in the midline.
Trachea is midline.
No other neck swelling is visualized.
Okay.
Horizontal skin crease scar present in the lower neck. The other skin is normal. No abnormal pulsation visualized. No abnormally dilated vessels. Palpation inspectory findings are confirmed. No tenderness is present.
When will you see the tenderness?
When there is perichondritis, cartilage invasion.
When you see a tenderness, you got to suspect cartilage invasion or perichondritis. What does that mean? It goes to a advanced tumor. Okay, tumor which goes beyond the mucosal level, causes infiltration. Okay, then what is laryngeal crepitus?
Sir, it has two components, cricovertebral and thyrovertebral component. If there is any soft tissue in between the larynx and the vertebra, then this will be absent, sir, like postcricoid growth or a retropharyngeal abscess. It will be absent, sir.
There are two components, right? What are the two components?
Thyrovertebral
click and the cricovertebral click. What is the surfaces which have got a thyrovertebral click?
The inferior horn of the thyroid.
The posterior lamina of the cricoid cartilage grating upon the body of the vertebra is cricovertebral click. Posterior lamina of the thyroid cartilage, that's a posterior border of the thyroid cartilage grating on the transfer process is called thyrovertebral click. Where will you get, what is that is called, otherwise called?
Boca's sign.
Boca's sign. What is Boca's sign positive?
Which means laryngeal crepitus is absent.
When the laryngeal crepitus is absent, that means Boca's sign is positive. When the Boca's sign is positive, patient has got
either
post-cricoid growth. Patient has got disease. Okay. So when the Boca's sign is negative, patient is normal. All of us have got Boca's sign negative. Unless you have some soft tissue intervention like a post-cricoid growth, where Boca's sign will be negative. Okay. What is the other sign?
Muir's sign.
Muir's sign. It's called cricovertebral click. Where it will be absent? Cricovertebral, if you press the cricoid cartilage, if you have a small post-cricoid tumor, you can still see. It is absent in the case of unilateral absence of thyrovertebral click is in the large pyriform fossa tumors. If you see a large pyriform fossa tumors, unilaterally the click will be absent. What else is seen on an examination in a case of a post-cricoid tumor?
Pooling of saliva.
Neck
nodes.
You can see nodes. Then on the laryngeal framework,
membrane.
The laryngeal cartilage will get widened. Splaying of the laryngeal cartilage. Splaying of laryngeal cartilage is the characteristic feature of post-cricoid tumor. Unilateral splaying is seen in
pyriform fossa
tumor. So when you see a unilateral splaying of thyroid cartilage, it can be because of tumor. Okay. So I am telling you, this patient has got a swelling in the neck. Okay, swelling in the neck. What are all things you will see? Site, okay, at the level of C2, C3.
Size of the tumor.
Shape of the tumor.
Then the mobility of the tumor. Then skin pinchability over the
skin above the tumor. Okay.
Warmth or tenderness.
Then Scar, fistula, puree orange. How do you know the plane of the swelling?
Sternocleidomastoid
You
contraction.
contract the neck muscles to see where the tumor is, what plane the tumor is. Usually, what is the what will happen?
It will go beneath because the jugular nodes are beneath the sternocleidomastoid.
Sternocleidomastoid. So when you contract, it will become less prominent. Okay. So what will happen if the tumor is over over that plane? If there's a subcutaneous one, what will happen if you contract the muscle?
It will become
It will become more prominent. Okay. If it is infiltrating that muscle, what will happen? If you contract the muscle, it will not alter the size, but it will become more fixed. Okay, it will become more fixed. Okay. Anything else you see? Just lateral swelling around the level of the anterior border of sternocleidomastoid, C2, C3 level. Anything else you see? What it should be?
Nodes, sir.
Node, right? How many percentage of a pyripompocyte tumor will present with 2, 3, 4 nodes?
60
to 70% will be present with 2, 3, 4 nodes. Anything else can present like this?
Nasopharyngeal.
See the pyripompocyte growth present with the neck node, which is not malignant node, which is not neck swelling, which is not a malignant node. Anything else can present like that?
Growth itself can present.
Come on, Ravi. Yeah. I never told you it's a node. You have a swelling.
Supraglottic tumors or supraglottic tumors can present with nodes.
I'm not talking about node. This is not a node. Anything else it can be.
Laryngoscopy.
Pyripompocyte tumor.
It itself can.
Where it is spread?
Laterally via the thyroid membrane, it can come out and.
Then you can palpate, no?
Yes,
so a tumor,
laryngeal tumor.
A tumor which comes out of the framework. Hypopharyngeal tumor, particularly, I told you the lateral wall is partly membranous. So a superficial part of the pyripompocyte tumor can come out of the laryngeal framework externally, can be present as a neck swelling. Okay, how will you differentiate this swelling from the node? Anyone?
Moves with swallowing, sir. Moves with swallowing.
Moves with deglutition. A tumor which is attached to the larynx moves with deglutition. So, hypopharyngeal tumor coming outside will always move with deglutition. Can come out at the thyroid membrane, or it can come out at the level of the C6 cervical vertebra. It can come through the in and around the cricoid cartilage. It can come out. Okay. So that you got to keep in your mind. Okay, why you should check for skin over the swelling, pinchability, plane of swelling, and all in a case of a node?
Fixity to the changes the upstages. The
fixity is old terminology.
Extracapsular spread.
Extranodal extension. Extranodal extension is called. It's a if you want to check the extranodal extension in a tumor, if a CT scan will tell you extranodal spread, but that is not sufficient to say a tumor extranodal spread. Which is when you say the patient who has got an extranodal spread in a clinical examination, what nodal status is that?
N3B.
N3A. I mean N3B. So you are going to upstage it as a stage 4 disease. To say a stage 4 disease, you can have a solid evidence. But the same thing when you do a radical neck dissection, you take the node and send it for biopsy. In the biopsy, they said extranodal spread. In a single tumor, 3 to 6 centimeters duration with an extranodal extension is in a pathological examination is
that is also less than 3 centimeters is
N2B is that's called, that is N2.
N2A is
N2A.
centimeters with extra nodal extension.
So single tumor less than 3 millimeter with the external extension is N2A. That will be very small extension because it is a pathological examination. But the same thing when you say it as a clinical examination, external extension is otherwise a synonym of fixity. So external extension is N3B disease. Okay, so this is about the examination. Okay, so whenever you see a tumor, you got to be very careful to see whether there is any fixity or whether there is any extra nodal extension. Okay, right. Carotid pulsation. Where is what is the why do you want to see carotid pulsation?
Tumor spread lateral carotid encasement.
Encasement of carotid is a rule in the case of an hypopharyngeal growth and it extends laterally. Okay, so if it's the carotid is encased, what will happen to the lumen?
Lumen. Initially, it will not.
Initially, it will not happen. If it becomes bigger, what will happen?
First,
Otherwise, what else you will look for when the carotid is encased?
percentage of encasement we will look for.
That are all radiological. On examination, how you see? You see a tumor sitting on the carotid. What do you see?
Mobility will show the mobility along the vertical.
Pulsations. You see the pulsations. What else you see?
Mobility along the vertical
That,
plane
yeah,
will show the
vessel,
extension into the vessel.
Yeah, vessel which is blocked will produce what?
Bruit.
Feel it is called what?
Bruit.
Bruit is head. It is thrill. So you should look for a carotid thrill. Which side carotid will produce thrill? It's a basic question. Which side carotid will produce thrill? A tumor which is at a right side node. This patient is left side tumor, left side node. Pressing upon the carotid, you can't move it vertically or horizontally. Which side you will look for thrill? Opposite side. Involved side. The thrill can come on both sides. A tumor which is partly obstructed will produce a thrill and produce a bruit. If the tumor is obstructing more than 75%, what will happen to the blood supply to the brain?
It will decrease. No, it will.
Blood supply to the brain cannot get reduced. It needs more blood supply. Where you get the blood supply?
Compensated from the
Compensated from the opposite side. Hyperdynamic circulation on the opposite side can produce thrill. So you should not restrict yourself looking for thrill only on the affected side. Also, you should look on the opposite side. But you should not palpate on both sides together. Right? When you palpate carotid, you should not palpate both sides together. Okay. So this is about the examination of the carotids. Okay. And then all of you should carry a step to your exams, at least to your exams, because even if you don't look for a thrill, at least give a acting as if you are looking for, because examiners will be there looking at you. Okay. So then what else? What other things you do? No palpable thyroid on the left side.
Semithyroid.
Is it because of that? Why palpating a thyroid is important in a hypopharyngeal tumor?
Thyroid swelling can also be a presentation of this.
Yeah, thyroid swelling can thyroid
Swelling.
fixation will be the presentation of an hypopharyngeal tumor sometimes. An anterior tumors, piriform fossa tumor can escape and infiltrate on the thyroid cartilage. When it comes out of the framework, it can cause infiltration of the thyroid cartilage. So thyroid gland. So a thyroid gland involvement is also a feature of a external spread of a tumor. Okay. So you should always look for thyroid. Also always look for the swelling which is moves with the debilitation. Okay. So fine.
Ear and nose examination.
Ear and nose examination. Do you have anything in particular you want to tell on the ear examination? You told me ear pain.
There, but
so ear is normal. So left ear there is no referred. I mean there is no left ear is clinically normal, which means the pain what is called is the referred atalgia. What is referred atalgia?
Pain elsewhere presenting as the pathology elsewhere presenting as pain in the ear because of same nerve supply.
What are all the nerves which will produce referred atalgia?
9th and 10th nerve.
That's all? 7th nerve will not produce. Wait. What are all the nerves which will produce referred atalgia? 5th nerve. Through what branch?
Auriculotemporal branch.
Auriculotemporal nerve. Okay. Then
9th nerve.
9, 10. Then cervical nerves. C2, C3. So neck pain can be present as a ear pain. A dental pain can present as a ear pain. A glossopharyngeal nerve, posterior one of tongue, tonsillar pain can be referred as a can be present as a ear pain. You would have seen all the patients who underwent tonsillectomy on second or third day invariably will complain of ear pain. We always think that it may be because you are injured the eustachian tube, but it can be because of referred atalgia. Okay, so referred atalgia is a pain in the ear because of disease somewhere else. It can be because of cervical nerves, or because of 5th nerve through an auriculotemporal, or it can be because of glossopharyngeal nerve. Glossopharyngeal nerve goes through what nerve?
Jacobs.
Tympanic branch of glossopharyngeal nerve is called Jacobson's nerve. Okay, tympanic branch of vagus is called Arnold's nerve. Okay, so a supraglottic tumor or a pyriform fossa tumor can present as a ear pain. Okay, similarly, any other tumor can it present as ear pain?
Tongue-based tonsillar tongue.
That is 9th nerve. It doesn't fit into any one of these nerves. Can it present as ear pain? A Chinese with a cotton in the ear. Next swelling, cotton in the ear, Chinese is a nasopharyngeal carcinoma, but it's not a referred pain, but the patient will have a eustachian catarrh or acute otitis media. A patient who has got a problem in the ear can be because of a tumor. That's a nasopharyngeal carcinoma. I don't want to deviate, otherwise I'll ask all the syndromes. Okay, right, fine. So this is about the ear. Nose. Okay, anything you want to tell about nose? I don't expect. Right.
Systemic examination, vitals were normal, sir. CVS, RS were normal, abdomen is soft.
I thought you were talking about bone pain when you are presenting history, right? So why?
Secondaries most common to the lung, liver, and bones, sir.
So that is an idea of examining
Systemic
examination. Okay. You have already seen the patient. If it's an exam in MMC, the common question is, did you palpate abdomen? All the students will tell yes. I used to ask, where is the couch? So before telling something, you at least see where the couch is. Then you should not search around. Similarly, when you say then abdomen, when the bone pain is not present, he'll ask you where are all you look for bone pain.
The vertebra.
Vertebral pain. Okay, you just give a knock on the cervical, thoracic, lumbar vertebra. Right. Then skull, long bones, ribs. All these things you should palpate for a swelling or any tenderness. Okay. Then RS. Okay. What is the difference between second primary and secondaries?
Cannonball.
Yeah, that's an X-ray, man. Primary are usually bronchogenic. So there will be a localized wheezing, or the patient will have a decreased air entry or collapse in the case of a second primaries. In the case of a secondary, you can see a peripheral lesion. This is the central lesion. Okay, so that is about the RS. Okay, but this also examiner will ask, raise your step, and then examiner will ask, okay, I'll go. You just call the. They simply say, call the patient. Let us ask whether this doctor examined with the step. So whether you keep that in your mind, always keep the step. Put 2-3 times. You listen or not is not a criteria. The patient should tell, yes, he has examined my bones and examined my chest. Okay, right. So, what's your diagnosis?
Malignant growth hyperpharynx subset left pyriform fossa T3N0MX in stage 3.
Why you say it's a malignant growth?
The age of the patient is 60 years.
See, this I've been keep telling in all these years. Okay, never say age of a patient, alcohol, patient is a smoker, because none of your examiners are going to be below 40 years. None of your examiners are going to be below 40 years. And most of them might smoke, most of them take alcohol. You tell them, they will skip a beat and they will start getting a intense hate to you. Okay, so don't tell this as a first reason. It may be true. You can always tell to your patient that if you smoke, if you take alcohol, so much amount of alcohol, you are bound to get a hyperpharyngal tumor. But you can't tell that to an examiner, right? So, and patient can always tell lie. You might feel little this thing and say, yes, I take alcohol, I don't take alcohol. That may not be true. What is more important is what you see. So now you tell me why you call this a malignant growth.
Ideal exam.
Yeah, ideal exam.
It's an exophytic.
I am telling you it's a benign tumor. Tell me one reason where I can't dispute.
Laryngeal fixation.
Slough can get out by
hemilarynx fixation.
hemilarynx fixed means infiltration. Infiltration means malignancy. You see a node, hard node, then it's malignancy. You see an averted growth, think of malignancy. Say a proliferative growth, think of malignancy. Okay, so a tumor which is called a characteristic appearance. It's a how do you present this case? Is there is a tumor involving apex of the left pyriform fossa, extending little up to the upper part of the pyriform fossa, little lower to the postcricoid area. I could not see the lower extent of the tumor, extending from the lateral wall to the medial wall and on to the cricoid joint. It's a proliferative tumor. Edges are all everted, warty, slough covered. Warty, slough covered tumor. Okay, these are all the areas it extends, which causes fixity of the vocal cord. So, this description says the tumor has got, this is a malignant tumor. Okay. So, then why is not a postcricoid growth?
So postcricoid usually extends inferiorly. More common is inferior, sir. Inferior extent. Submucosal extension inferiorly, and
how do you know it's not there?
Exophytic proliferative growth is probably a pyriform.
It's a postcricoid growth coming to the pyriform sinus.
Most common is inferior spread, sir.
Most common all you don't get
it will have bilateral cord fixation, bilateral.
Not necessarily. Patient started with
laryngeal capitis is not there.
Laryngeal capitis is present. Okay, laryngeal capitis is present. Opposite side pyriform fossa, there is no pooling of saliva. And more than that, patient's first presenting complaint 6 months duration is foreign body sensation. Okay, so this gives you an idea. It's a near pyriform fossa. What difference that makes? Once you investigated, is not going to make any difference because it is not a clear-cut demarcation between the postcricoid area and the pyriform sinus. So whatever it is, most probably we present this case as a pyriform fossa growth. Okay. What are the points against pyriform fossa growth? What are the points for? Yes.
Dr. Anthony, I have a question.
Yes.
When Dr. Raghavi presented, she said pooling of saliva is there in the other pyriform sinus.
No, so
Yes.
the left pyriform fossa.
It was the left pyriform fossa.
This pyriform.
Right pyriform fossa is normal. Okay. Even I thought of that. Some pyriform fossa, she told. I guessed it is left.
Okay.
Okay. Right. So it's a female patient.
Yes, sir.
So post-cricoid growths are more common in female compared with that of the pyriform fossa. But that is not a rule. Okay. So it can be it's a pyriform fossa growth slightly extending into the post-cricoid area because you don't see the lower extent of the tube with your indirect laryngoscopic examination. Okay. Right. T3 N0MX. How will you proceed with the case?
I would like investigations.
1 minute. Are we all right with the time, Janakiram?
No, I want you to do lot more time.
Yeah. Okay. Fine. Good. Now only we are starting the case. Yes.
Yeah, I know you are going to start only now.
Yes.
Real scene is only now. I know
So
that.
how do you give a TNM staging for a pyriform fossa growth? Hypopharyngeal tumors.
Sir,
What is T1, T2, T3, T4?
T1 is less than 2 centimeters involving one subsite, sir.
Less than 2 centimeter involving one subsite. Yes.
T2 is more than 2 centimeters, not exceeding 4 centimeters, involving more than one subsite or any adjacent areas, sir.
Okay.
T3 is more than 4 centimeters or involvement of the esophagus, sir. T4 is moderately advanced. T4A is moderately advanced tumors where there will be involvement of thyroid cartilage, cricoid cartilage, thyroid gland, soft tissue of the.
This hypopharyngeal tumor. Why should it involve esophagus at such a long distance and still you call it as a mildly extended tumor?
T3, there is hemilarynx fixation also, sir.
That's I'm talking about the AJCC tumor criteria. Why this is called esophageal involvement is esophagus is far off, right? Why it is called only T3?
Post-cricoid can involve esophagus, the cervical esophagus very commonly, sir. Submucosal spread can be there.
Submucosal spread is a rule in the case of a pyriform fossa growth. I mean, the hypopharyngeal growth. Which growth produces more submucosal spread? Which produces less submucosal spread?
Post-cricoid causes more submucosal, sir. Pyriform sinus causes less.
Why?
Loose areal
tissue. Yes, there is a submucosal lymphatics.
lymphatic spread.
Submucosal lymphatics are more in the case of a esophagus as well as the post-cricoid area. So esophageal tumors spread more submucosally. So you can get a skip lesions. It can go up to the 10 millimeters. But the advantage of this is, blessing in disguise with this is, the submucosal spread doesn't adversely affect the management of the tumor or the survival of the patient. Okay, so it doesn't immediately affects, but the submucosal spread is not so much in the case of a hypopharyngeal tumor or the pyriform fossa tumor compared with that of the esophageal tumors. Okay, that's why even though it is the 1 centimeter away, esophagus is only T3, and it can remove it incontinuously easily without compromising the tumor clearance. Okay, then T4A is
involvement of moderately advanced, sir. Involvement of thyroid cartilage, cricoid cartilage, thyroid gland, the soft tissue. Of
thyroid gland involvement is T4A.
T4A.
T4A. So every time you examine a patient of an hypopharynx, you should always examine for thyroid cartilage, palpate for the thyroid cartilage, look for movement of the thyroid cartilage, thyroid gland on swallowing. Okay, right.
Then T4B is involvement of prevertebral fascia, the mediastinum with the carotid.
Prevertebral fascia, mediastinal carotid, and mediastinal structures. Okay, I already told you how to examine the carotid as well as the prevertebral fascia. Okay, what are the nodal stages?
N1 is single unilateral neck node of less than 3 centimeters. N2 this is the clinical staging without extra nodal extension. N2 A is single ipsilateral node of 3 to 6 centimeters. N2 without extra nodal extension. N2 B is multiple ipsilateral nodes not greater than 6 centimeters without extra nodal extension. N2 C is contralateral or bilateral, not greater than 6 centimeters without extra nodal extension. N3 A is any node that is more than 6 centimeters. N3 B is without extra nodal extension. N3 B is extra nodal extension of any size.
So to say clinically an extra nodal extension, you got to see the node which is fixed to the other structures. Okay, so you got to see the plane of swelling. You can see whether the skin is infiltrated or muscle is infiltrated. Okay, or you can have a infiltration of all the vital structures. Okay, so this is about the nodal classification. Okay, how will you investigate the patient?
A direct laryngoscopy.
You want to do a direct laryngoscopy? Why?
Dr. Anthony.
Yes.
Professor, there's a question by Dr. Sanam Salim. Can you describe Muir sign again?
Describe? Unilateral absence of thyrovertebral click is called, absence of thyrovertebral click is called Muir sign.
Okay.
So
direct laryngoscopy to confirm my findings, look for the extent of the tumor, then take a biopsy, then palpate the
your idea is to look for
extent of the tumor,
geography of the tumor, and then biology of the tumor. Okay, so you want to do only direct laryngoscopy. What is the best investigation, combination of investigation to evaluate an hypopharyngeal tumor, to evaluate the oropharyngeal tumor or a esophageal tumor?
MR extension to the base of the tongue is which we prefer MRI, sir.
Base of the tongue usually should be examined by what?
Palpation.
Palpation. You got to put your finger there and see. Okay, but the oropharynx, the best way of investigating is CT MRI with biopsy. Okay, in a case of CT MRI, in a case of endoscopy, CT MRI. In a case of a hypopharyngeal tumor, endoscopy and CT MRI. In a case of an esophageal tumor,
endoscopy, anyway, rigid esophagoscope wouldn't go inside if there is a tumor, sir. So CT MRI, barium swallow can be done.
Endoscopic ultrasound.
Endoscopic ultrasound.
You got to do an endoscopic ultrasound and PET scan. Okay, that's the best way of investigating for a esophageal tumor. Okay, so for to examine, first you got to do a complete hemogram. What are the
general blood investigation?
General blood investigation.
Then chest X-ray, ECG.
Why you want to take a chest X-ray in the case of a malignancies? Secondary.
For anesthesia fitness.
Anesthesia fitness.
Look for tracheal
associated
tuberculosis. Tuberculosis can be
associated disease like tuberculosis. Then
mediastinal widening.
Mediastinal widening. Where do you get mediastinal widening?
Mediastinal lymph nodes.
Whenever the tumor goes to piriform postcricoid area or an upper esophagus, can get a mediastinal node. Similarly, a laryngeal tumor which goes subglottis can produce mediastinal widening. Then Okay, this starts as a pilot film. What is the pilot film?
Later on, when we take when the patient comes to follow up, when we take a film, we can compare it with this film to
So
see if there are any.
pre-operative film is mandatory. So pre-operative film, you got to keep it. Okay. Then first is pre-operative film. Second one is you look for secondaries. Third is second primary. Fourth is mediastinal widening. Okay. Fifth is aspiration pneumonitis. The tumor has got a vocal cord fixity. Patient can have a silent aspiration. Now look for aspiration pneumonitis. Anything else you will do, you look for an anesthetic purpose. Okay, cardiophrenic angle, costophrenic angle are all you can't examine with your this thing. So what is the best investigation we do it now? We do a HRCT. Okay, so CT chest is important. Okay, then why do you want to take X-ray? X-ray neck, AP lateral. Why you want to take X-ray neck AP lateral?
Widening,
Prevertebral shadow widening. Then subglottic air column. Okay, then because anterior wall is nothing but the larynx and trachea, so it can infiltrate subglottic area. Anything else? Bone involvement.
Straightening of the
straightening of the cervical vertebra. Okay, for all these purposes, you got to take X-ray. AP lateral. Why you want to take AP view?
Tracheal midline.
Tracheal position. These patients can go in for stridor anytime. So you need to do a tracheostomy. So it's all almost outdated. Okay, now you do CT scan. Why you want to do a CT scan?
Find the extent of the lesion.
Extent of the disease.
Node spread.
About extraluminal spread. Extraluminal spread. Then
Nodal status.
Then calculate the volume of the tumor. Show the lower extent. Most of the time you can't see the lower extent with your clinical examination. So you can see the lower extent with your radiological investigation. Right. Then one investigation. Will you take an MRI?
For cartilage invasion, to check for cartilage invasion or base of.
If you check a cartilage invasion, which is the best investigation? CT or MRI?
If there is CT, sir, because of
CT. What is the finding of cartilage invasion in MRI?
The spleen. We can differentiate between spleen.
T2 weighted, it's a increased intensity, and the T1 weighted, it's a decreased intensity. We will give you an idea, but the best investigation is CT scan. Okay, right. MRI is done to see the neural status, soft tissue extensions. Okay, particularly the base of tongue involvement. Okay, will you take a barium swallow?
Yes, sir.
Yes or no? No need.
We have done CT scan, then it's. We need.
You can take, if you have time, you have money, take, or no, don't take.
We need to take, sir, any esophageal.
Always you got to take a barium swallow because
lower extent, any second
lower
primary
extent,
in the esophagus.
Skip lesions, second primary. After all these things, how do you see a barium swallow? How do they report a barium swallow? Barium swallow is seen on fluoroscopy. So fluoroscopy,
irregular.
it's all not important. You can see the tumor infiltration. When the patient swallows, you can see whether the larynx moves up and down. The larynx is not moving up and down, then you know the larynx is infiltrated. There's a difference between a tumor which is going inside the prevertebral space and the tumor which is infiltrating prevertebral space. So if they are not moving, we don't think of
Postgrade.
If it is not moving, infiltration to the prevertebral the muscle, what you do or what you don't do?
We do not operate.
You don't operate. It's a contraindication to do a radical surgery. You can't give a cancer clearance for a involvement. Okay, right. Then barium swallow is done to see the mobility of the larynx. When you want to operate on a larynx or a hypopharynx, first thing you do is you open up the neck. Once you open up the neck, you look for cavity on both sides. You see the viscerovertebral canal. Just open up and see whether it is free. Second thing is you see the mobility of the larynx. So you see whether the larynx can be separated from the posterior pharyngeal wall, or the posterior pharyngeal wall can be separated from the prevertebral soft tissues. Then you can proceed with the surgery. To assess that preoperatively, you got to do a barium swallow. One investigation which is replacing all other investigation of spread is PET CT. Okay, PET CT is giving you a preoperative as well as the postoperative evaluation of distant metastasis. Okay, so it's a very good tool to find out whether the patient has got any other distant metastasis. Okay, these are all the investigations you do. Then only you do a direct laryngoscopy. Okay, so direct laryngoscopy, what are all things you do?
Take a biopsy.
You take a biopsy. Why you want to take a biopsy?
Proof that proof of histological
Histological evidence of
malignancy.
Or not. So you want to take the biopsy to see whether the patient has got a benign disease or a malignant disease. Okay, that's the first one. Second one is if it's a malignant disease,
Carcinoma subtype.
you want to see the subtype, whether it's carcinoma or sarcoma or various types of carcinoma. Okay, so when you keep on taking biopsy on a warty tumor, it is becoming negative 2-3 times. What do you think of?
Verrucous
Carcinoma. Okay, verrucous carcinoma, you get a warty tumor. If you don't take a deep biopsy, difficult to get the histological evidence. Okay, then what else? Why you want to know whether it is
differentiation?
Why you want to know whether it is what type of malignancy it is?
The treatment protocol.
For the
Treatment protocol.
treatment protocol. Okay, then the treatment for squamous cell carcinoma is entirely different from that of the other type of malignancies. Okay, then you look for differentiation. So what classification is that?
Broders classification.
Broders classification. What is Broders classification? Okay, if it is an anaplastic or undifferentiated carcinoma, or it's a well differentiated carcinoma, why should you do it? Why do you want to
Prognosis.
to tell the prognosis of to assess the prognosis of the patient? The tumor which is a poorly differentiated will have a poorer prognosis compared with that of the well differentiated carcinoma. Okay, what are all the other prognostic factors which will adversely affect the patient?
Nodal status.
Nodal status. Why?
So node decreases the
How much?
50% it decreases.
So one single palpable node will decrease the
Prognosis by 50%.
prognosis by 50%. So a palpable node is difficult for the patient to manage. Okay, then you take a biopsy. It comes as a moderately differentiated squamous cell carcinoma. For this patient, what are you going to do?
I can, depending on the lower extent, sir, if it's not involving the apex, sir, I'll go in for a multimodality treatment, sir.
Multimodality treatment, okay.
Concurrent chemo RT.
Hmm.
Then we'll go ahead with the surgery followed by post-op RT.
You want to operate on the patient?
No, sir, she has laryngeal functions, so I would like to try concurrent chemo RT
You
first.
want to do an organ preservation.
Organ preservation.
Want to do an organ preservation. So, first, stage 1 disease or a tumor which is T1 and T2, you use a single modality. A tumor which is stage 3 or T3 tumors, you have a
Multimodality.
Multimodality.
Cure.
T4A, we operate. T4B,
We do not operate. Palliative
only
radiation
palliation.
treatment.
Okay. So what is curative? What is palliation?
Palliation is relief of the symptoms, but not attempting cure for the patient, sir. Whether
Palliation is a modality of a treatment by which you alleviate the patient's symptom without expecting to improve the cure or cure rate of the patient. That's called palliation. Okay. So whenever you tell a treatment, you got to tell whether you are having a curative intent or a palliative intent. Without this, if you are telling your management, it is not complete. So you got to tell you what is your intent in the patient.
curative.
Curative. You want to cure the patient. Okay. So what is the what are all the various modalities available?
Chemo radiation therapy or surgical therapy followed by post-op radiation.
Okay. Usually we prefer giving a
Induction.
chemotherapy. Whether you want to do the concurrent chemotherapy or
First induction chemo, looking out for responders and complete responders. You can continue.
fine. So okay. So we don't have that study and all here. So in MMC we send all these patients for chemotherapy. Okay. It's not an RTOG center. Okay. So we give what are all the drugs which is given for chemotherapy? Cisplatin.
100 mg per meter square per day.
Okay.
Given on first, 8th and 23rd.
First day, 8th day and 23rd day. Okay. Cisplatin with
5 fluorouracil.
5 fluorouracil. You give any taxanes?
Dr. Taxil.
Paclitaxel or docetaxel? Then any other drugs you give?
Methotrexate.
Okay. So you give a induction chemotherapy. Then you give a followed by a radiotherapy. Okay. How much radiotherapy you will give?
Curative radiotherapy 60 to 70 gray, given in two gray fractions per day, for 33 fractions over a period of 6 to 7 weeks.
What is the outcome of this therapy? Particularly if the patient has got a post-cricoid growth, the patient has got a dysphagia, then if that is the case, what will happen if you give a chemotherapy? Patient, even if the patient gets cured, what will happen? What's the sequelae of this? Patient will develop strictures. So if the patient develops strictures, then you might need to do a failed vaginestomy and the patient should be lifelong on support. Okay, so that defeats in one purpose of treatment.
Curative.
I mean, that's organ preservation. The functions of the organ we are going to preserve are, one is laryngeal function and second one is pharyngeal. Do you think this cord will become mobile?
No, sir.
Sure. Can become mobile because you don't know what is the exact cause for the thing.
If it's not a deep infiltration, then there is a
chances for it to become mobile is higher. Okay. So if the patient develops stridor, then what do you do?
Then we'll have to do an emergency, first an emergency tracheostomy for
Why?
high tracheostomy we'll do. High tracheostomy so that when we do a total laryngopharyngeal.
You want to do a total laryngopharyngeal for this patient?
No, sir. There is post-cricoid involvement.
That all come if you are going to operate immediately. That's for the vocal cord growth with the stridor. Laryngopharyngeal growth, your intent is not going to do surgery for this patient, isn't it? Yes, then do a tracheostomy. If you do a tracheostomy, what will happen? Patient will lose the laryngeal function. Laryngeal function. That is, then we're giving a complete intent of giving an organ preservation is failed. Okay. So you got to be doubly sure that this patient is not going. Patient is not getting compromised on his cure in the view of organ preservation, because already patient has got chances of losing the function. Okay, right. If the patient is not willing for radiotherapy, then what will you do?
Then we can operate and then give post-operative.
What surgery you will do for the patient?
This patient, total laryngectomy with partial pharyngostomy.
No, this patient has got apex of the piriform fossa involved. When the apex of the piriform fossa
Total
is involved,
laryngectomy has to be done, sir.
you got to do a total laryngectomy and the
Partial pharyngostomy.
total pharyngostomy. Okay, if you are going to do a total pharyngostomy for this patient, what is the lower extent of the tumor? If the tumor extends into the post-cricoid area, then what will you do?
Then 2 centimeters margin. Skip lesions will be there, sir. So we have to first evaluate for that if there is any lesion in the esophagus, and then decide.
Some recurrence will be there. So if the post-cricoid tumor, post-cricoid is involved, the ideal surgery is
Esophagectomy with gastric pull-ups.
total laryngopharyngoesophagectomy with gastric pull-up. That's called
Angs
surgery. If the same patient has got a lesion which is on the superficial part of the piriform sinus, on the lateral wall, then what you will do?
Then with hemilarynx fixation, sir.
Without hemilaryngeal fixation.
Partial laryngectomy with partial.
That is, what tumor is that? What tumor? Tumor stage?
T2.
T1 or
T1 and T2.
T2? So what do you do for T1 and T2?
Curative RT is the treatment.
Curative RT. The patient is radio recurrent, then what will you do?
Then we'll operate, sir.
Operate what?
Partial pharyngostomy with partial laryngectomy.
We do only partial
Partial
pharyngostomy. Why you want to do larynx? Why you want to touch larynx? It's on the lateral wall. So only you do a partial pharyngostomy. How do you approach a partial pharyngostomy?
Transoral approaches and transcervical approaches. Transcervical.
When you talk of surgery, you are talking from outside. You are not talking robotics.
You're not?
Okay. It is not transoral robotic surgery. Right? If you don't operate outside, you do a partial pharyngostomy. Partial pharyngostomy will be because through a lateral pharyngostomy or
anterior suprahyad.
Suprahyad approach, exposure, and then you do a partial pharyngostomy alone. The same thing is on the adioepiglottic fold. Then what do you
We'll
do?
have to do a partial laryngectomy. Hemilaryngectomy.
You do a partial laryngectomy with the partial pharyngostomy. Or you can do a near total laryngectomy with the partial pharyngostomy. How will you reconstruct a partial pharyngostomy?
Depends on the remaining mucosa, sir. If it's adequate, then we can do a primary closure. But if we feel that there will be tension, then we'll have to augment it with some other reconstruction.
Like
Skin graft if it's very small, or
skin graft.
face PMMC flaps.
Pec major. You want a lining alone. Best flap is pec major, which is a workhorse of ENT. Okay. If you are very well versed, you want dexterity, then what will you do? You do a faciocutaneous microvascular flap, or you can do a jejunum microvascular flap, or omental with gastromental flap. Okay, you do a microvascular flap. Okay, if you have a patient who got a vocal cord fixity, then what will you do?
Then total laryngectomy we'll do, sir, with
Curative chemotherapy. If it is not involving, then the patient is not willing, or radio recurrent, then what will you do?
Then total laryngectomy with partial
Total laryngectomy with partial pharyngectomy with
reconstruction.
reconstruction with
Either flap or microvascular. reconstruction.
same thing, pet major or a microvascular flap. Okay, if the remaining mucosa is not adequate, or if the tumor goes to the posterior pharyngeal wall, then what will you do?
Then we'll do a total laryngectomy with total pharyngectomy.
Total laryngectomy with total pharyngectomy. Then how will you? You got to necessarily do a free flap. If you don't have a free flap facilities in your hospital, then you are in trouble. You can make a tube reconstruction, but it's all, it will go for scarring, stricture, very difficult to manage, failure rates are very high. Okay. If it is a post-crical is involved, then what do you do?
No fixation, sir.
With
Laryngeal autograft.
otherwise, what are the indications for surgery in a case of a hypopharyngeal tumor?
Fixation of the larynx.
Radio recurrent growth,
Radio
radio residual growth.
Tumor volume more than 4 centimeter
Then
cube.
tumor volume is more than 4. If a patient is equivocal, wants surgery or radiotherapy, then you can do surgery in these type of cases like tumor volume more than
4 centimeter.
4 centimeter square. Then
Vertical length more than 5 centimeter.
vertical length more than 5 centimeter.
Hemilarynx fixation.
Hemilarynx fixation.
Cartilage.
Cartilage erosion. Skin infiltration.
Skin.
Then mobile neck node. Mobile neck node. These are all the indications that you can do a surgery for the patient. Okay. So if there's a post-cricoid growth with the vocal cord fixity, what surgery you do?
Total laryngectomy with total pharyngectomy with esophagectomy with gastric pull-up.
Esophagectomy with gastric pull-up. Okay. If the stomach is already removed already,
No,
then what do you do? Oh, you pull a jejunal loop, roll Y.
Colon transposition or jejunal.
You have a microvascular facility or not? If you have a microvascular facility, what do you do?
We can use the
Colon. I mean, sorry, you use a jejunum free flap, long jejunum flap with a microvascular anastomosis. Okay, if you don't have a microvascular anastomosis, you do a colon interposition. Okay, what are the colons available for interposition? Which one you will do?
left colon will do.
Left colon or
Left colon.
you can use a left colon or right colon. Which is better?
Left is
Why?
handles semi-solid.
It handles semi-solid. On a right colon, the food goes to a right colon is a fluid. The main function of colon is
Absorption of
water. So it absorbs all the water. Slowly it becomes semi-solid. When it travels the left colon, it is usually semi-solid. So you can use that for an anastomosis. Okay. So what is the have you seen a total laryngopharyngectomy? So what are the complications of total laryngopharyngectomy? Immediate complications.
Pharyngocuteneous fistula.
That's all late. That day, what happened?
Anesthetic. Total laryngectomy பண்ணியாச்சு.
How do you pull it?
Medius pneumothorax.
Pneumothorax. Hemopneumothorax. Injury to the
Great vessels.
thoracic vessels, great vessels. Okay. The major surgery can cause infection, produces dramatic mediastinitis and complications. Okay. So these are all the extra complications other than total laryngectomy. Okay. So the thorax is very important. Okay. You got to keep the patient on ventilator for for 2-3 days, because if there is any respiratory eventualities, it is much easier to manage. Okay, so with this, what do you think is the 5-year survival rate of this patient?
Less than 30%. 30%.
When you talk of hypopharyngeal tumors, we talk about 2-year survival rate, 3-year survival rate, then the 5-year survival rate. Okay, when the recurrence comes, usually it comes before
1 year.
1 year. Okay, usually T1, T2 lesion patient, about 40% patient survives 2 years. Okay, we have a very, if you do a T3 lesion, do some big surgeries like this, and the patient survives for 3 years, it's fine. The patient who got a bilateral nodes with this type of disease usually don't survive more than 6 months to the 1 year. So it's a reason. Why? Because you see all these patients reasonably advanced state only. So the survival is, unless you give a very good curative intent treatment, survival is very less. Okay, it's, I mean, very less in the sense it's not as good as that of the laryngeal tumors. Okay. Yeah, with this, I think we have done the exhaustive presentation. Actually, I thought we'll do it on 2 parts, but it's too boring to do it for 2 parts. Otherwise, you could have gone 1 part exclusively for management, and of the things for various surgical modalities. How do you approach? What incision you do? Can you do what type of neck dissection you do? When you have a bilateral node, which one you do? All these things we could have discussed, but seeing the face of Raghavi, we have decided to.
Dr. Raghavi has done very well. Extraordinary knowledge and very, very well done, Dr. Raghavi.
Thank you.
All give a big hand. Now, I have a few questions. Dr. Anthony, we want one more classroom on that is just radical neck dissection and functional neck dissection, and also treatment modalities for piriform sinus. And can you do that as a separate classroom?
Yes, once your backlog is over, anytime we will do it. But this classroom is mainly for a clinical examination, I think. But neck dissection and other things, the clinical examination part will not have it in your exams. It will be a part of other things. But we'll do it definitely. That's not an issue.
Okay, that is one. Second is we want to also do one the next grand rounds with you. That is on 22nd. We have a grand rounds with Ahmedabad, and we want to do one with you. Can you give a date for the next? I will discuss with you because.
Yeah, sure.
Yeah, we would like to do on CSYM, say unsafe type or anything like year.
Yeah, very much.
Yeah, so you can give us the dates because the exam is coming in, I think, April or May. We want to do as many classrooms, the grand rounds as possible from you also, because you're giving exhaustive. This was very exhaustive. Fantastic classroom. This is the sort of mind-blowing classroom which we had grand rounds. I think every postgraduate will really enjoy. And usually...
Let me have the pleasure of telling this. When she is presenting, I had a sort of memories of JANAKIRAM presenting his finally, he is a gold medalist from our MGR University. I think he has presented same case, piriform growth with vocal cord fixity. And as usual, he has mesmerized the examiners.
No. Actually, I was super tensed. When you asked the questions, I was answering. Ask the questions I didn't know, because now so many recent advances, and I'm sure that all the postgraduates would have really got jolted, because the kind of questions you are going to ask, I think it's going to be super tough level when you come as examiner. I'm telling you, you're rising the bar by many levels. And if you come as examiners, I think now in Chennai, everybody's stomach will be like, fluttering because your in-depth knowledge. You the first person, I always say, if there is a 6th edition Scott Brown, you'll be the first person to read it in the world. If there is 8th edition Scott Brown, you will be the first. Every edition, he gets it, he reads page by page. So the student has to be thorough with all the books. You read, I remember you read Batsakis, Eugene Mayer's, all the books. I think you are the only PG I've seen who read for radiotherapy a separate book, for this one, what is that? For cancer, separate book. Batsakis used to recite. So really, you are the right person to conduct the exam. And it is also scary. When you are an examiner, it's really scary. But today it was a little fun because you gave most of the answers also. But when it comes to exam, I think they have to be really prepared. So I think that Dr. Anthony, Professor, thank you very much. Actually, since you're my classmate, I'm calling you Dr. Anthony. Actually, I should call you Professor Anthony. Now, can we also know the names of the other postgraduates so that the world will know who are all there from MMC? Can you? This is always an ordeal we have with all the grand rounds. And,
Introduce yourself, everyone.
I'm Dr. Sharmila from the
which year?
second year diploma, sir.
Okay, please. Yeah. All of them are from Madras Medical College?
Yeah, everyone is from, there is good news. From next year onwards, there is no diplomas.
Oh.
We are going to have 30 MSPGs every year.
Wow, fantastic.
So 90 people will be coming for will be in the institute every day. Next time you come to arrange a workshop, you need not call anyone. Even MMC alone can do a workshop.
Okay, fantastic.
Yes.
Yeah, the other postgraduates, please.
So I'm Dr. Sara Mary Tampi, first year MS PGs.
Okay.
He is our Talabadi.
MS second year.
Oh, the post you made, Talapathi's birthday.
Yeah. He is the one.
Okay. Great.
Jodhishwaran.
I'm Dr. Ilamati, second year DLO.
I'm Dr. Manimala, second year DLO.
I'm Dr. Lavanya, first year DLO.
Dr. Dhanalakshmi, first year DLO.
Dr. Sara, first year DLO.
Hi, sir. I am Dr. Ginny, first year DLO.
Dr. Barney, first year DLO, sir.
Dr. Arif, second year DLO.
I'm Dr. Sunil Kumar, second year DLO.
Yeah. Okay. I just want to add one comment, Professor Anthony.
Yes.
Actually, people actually think that DLO means it's actually a waste. Actually, in our times, we had to do DLO before MS. I hope you agree with it.
Yes.
And we always used to say post DLO MS is far better than state MS, and we used to be far superior to the state MS. Am I right or wrong?
Yeah, absolutely.
Because we used to do 5 years. I honestly believe that doing 5-year MS is definitely better than a 3-year MS. And I think those who are doing DLO don't ever get prejudice. I used to get a little complex by saying DLO, but actually post DLO MS is far superior to a state MS examination, because you get to read for 5 years and you get to read more books, you get more exposed. So to those who are doing DLO throughout the world, I think today we have the maximum traffic on my YouTube. It's getting like, maximum viewership. It's all because MMC is conducting the grand rounds. And those who are doing DLO all over the world, don't ever get complex because you're doing DLO and MS like that. And I honestly believe 2-year DLO and then a 3-year MS is definitely superior to a direct 3-year MS. This is my belief. I think Professor Anthony, you can comment on that.
Yeah, definitely. It's only years of experience and how sincerely you have just put into it. After 2 years, you can always go for some fellowship or some training somewhere, and you can do as good as all other people, right? So it's only your exposure. And there are people who do 3 year MS course and they're not at all interested and they don't learn anything, but they never be superior to you at the beginning. For a start it might look little weird, but ultimately your quality and your knowledge counts than anything else.
Yeah, exactly.
Okay, I want to thank my people, Dr. Lalimai, Dr. Rosie, Dr.
Lalimai, speak because she's always your backbone, your strength. Can you bring her to the this one, please? You all want to see her, actually. The world wants to see her.
All three of you.
Yeah, Dr. Lalimai, please come. You are the backbone of the whole. Yeah, so nice, actually. Thank you very much, madam. It's always a pleasure. Oh, madam also is there, is it? Wow. Okay. This is Professor Anthony's Mrs., I think.
Yes.
Welcome, madam. Welcome, welcome.
This is Dr. Niveda.
Oh, Dr. Niveda. Welcome, welcome. So the whole team is there. We are really proud, actually, to see the whole team. And yeah, so nice and fantastic grand rounds. One of the best we have had so far. Very, very big thanks. And we want the next date also from you, Professor Anthony.
We'll discuss, JR.
We'll discuss that. And all thanks to Alembic, and because they are bringing these programs to the doorstep of every postgraduate around the world. And a big cheers and applause to Dr. Raghavi, who did fantastic, actually. Very brilliant ENT surgeon in the making. Of course, under the headlines of Professor Anthony, anybody will become, he will turn a stone into diamond. So you're already now a diamond now. So great, Professor Anto, and thank you very much, and have a nice day. We have done it.
Yeah, I want to give a special thanks to our audiovisual team, and they have been here for the past 2 days.
Yeah, I really forgot. Actually, Banyan Tree, I'm telling you, they are rocking now. Everywhere they are rocking. I'm so happy with them, and Alembic and Royal Pearl, they are very, very happy. I recommend them to everybody who I see now. Banyan Tree, you can come forwards, and really a big hats off to you, your dedication. There is no problem in the streaming at all, and you're doing a great job. Very, very well done, Banyan Tree. And yeah, people who are doing streaming, live streaming in the future, you can definitely contact this great gentleman. He's actually a very thorough professional, and he does a very nice job. I strongly recommend him. Wherever I'm going to start, I'm going to tell him about live streaming. Very good, very good. Well done. And do you have Alembic people there? Do you have Alembic?
Yeah. Manohar is here.
Hello, Mr. Manohar. Very, very well done. Convey my regards to Mr. Rajit. Yeah, you're doing a great job.
Yeah, Arabic people were with me, on top of me for the past 2 weeks, always asking, what are you going to do with this? What are you going to do with this, that, and all? And they've done a fantastic work.
Yeah.
Thank you very much.
Thank you very much, Professor Anthony, Team Alembic, and Banyan Tree, and the postgraduates, and the examinee, Dr. Raghavi. And good night to all of you. It's late night. We have done it for 2 hours and 10 minutes. Record exam. I think if you do the same thing in an examination, I don't know what will be the, they'll be sweating. The candidate will be sweating if you ask these questions. Anyway, fantastic. Thank you very much.
Thank you.